Hello, and welcome to Rethinking Space and Place for Care, co-presented by Empowering Church Health Outreach. My name is Angel Moore, and I'm the Special Events and Committees Manager at CommunityHealth. CommunityHealth is the largest volunteer-based free health center in the United States. We provide primary and specialty care, prescription medications, mental health and dental services, health education, and labs, including COVID testing and vaccines, on the west side of Chicago. Our patients have no health insurance, and we provide all of our services to them at no charge. We do this with the support of over 1,000 volunteers, partnerships with dozens of institutions, and donations from generous people like you. Thank you for being here and for supporting Community Health. I would especially like to recognize our many sponsors who are supporting this year's All-In series, including Baxter, AbbVie, Lumbeck, and the Joseph and Bessie Feinberg Foundation, West Monroe's, and many others. I encourage you to visit our website, allin-chicago.org, to see the complete list of sponsors, read the bios for our incredible speakers, and check out the rest of the month's events. Finally, I want to recognize this year's All-In Executive Leadership Council. We have the privilege of having 4 outstanding leaders serving on the council this year. Their great insights and support have been instrumental in bringing this year's series to life. Thank you to Dr. Jay Bott, Mark Ishog, Brian Marcella, and Dr. Julie Morita for your contributions this year. The goal of the All in Chicago series is to bring together leaders from many different industries and segments of our population to talk about how we can work together to ensure every resident has access to the right care in the right place at the right time. Community Health has been hosting All-In events discussing access to healthcare in Chicago since 2015. This year, as we continue to navigate a global pandemic, the conversation around access feels as relevant as ever. COVID-19 has brought on not only public health challenges, but concerns about accessible healthcare and how it needs to be patient-centered. Today's panel will address the innovative approaches to redesigning the traditional place for healthcare. It is my pleasure to introduce our moderator for today's conversation, Josh Roberts. Josh is the president of ECHO, Empowering Church Health Outreach, who is co-presenting with us today. ECHO is a charity partner ministry of church health in Memphis that offers no-cost consulting services to anyone starting a free or charitable clinic anywhere in the United States. With no further ado, I will hand things over to Josh to frame things up and then to introduce our panelists. Thank you for being here, Josh.
Thank you, Angel. I'm thrilled to be here and moderate this panel that includes some of the most forward-thinking and innovative and compassionate people in free and charitable care. I know this is going to be a very insightful and thoughtful conversation. First, I'll introduce Dr. Cristy Daffron, who is a 37-year registered nurse who graduated from UAB in 1984. After spending 10 years at UAB in critical care, she found her true passion in nursing, community health. She has spent the past 25 years working in education, public health, faith community nursing, and hospice. In 2017, a divine appointment opened her eyes to the plight of the uninsured in her home county, St. Clair County in rural Alabama. Next up is Beth Kolb, who is the Executive Director of Trinity Health Center in Horn Lake, Mississippi. Trinity Health Center is a not-for-profit primary health care clinic providing care to the working uninsured of DeSoto County, Mississippi. Beth has been a registered nurse for 11 years and worked in the emergency department and home health before entering full-time ministry in 2016. Jenebra Winfrey-Porter is the Director of Medical Operations at Church Health in Memphis, Tennessee. Her daily work includes the operations of medical clinic, optometric clinic, physical rehabilitation, specialty clinic, and referral service lines. Originally from Philadelphia, Jenebra completed her master's degree program in healthcare administration at University of Memphis while working at a local Memphis hospital. She joined Church Health in 2014 and has served in multiple roles during her 7 years at Church Health, including successfully starting the quality department. Brianna Lathrop is the Chief Operating Officer and Doctor of Nursing Practice at the Good Samaritan Health Center in Atlanta, Georgia, where she provides executive leadership and direct patient care. She spent more than 15 years providing healthcare to individuals and families who lack health insurance. She is the co-author of a wonderful book, How Neighborhoods Make Us Sick, Restoring Health and Wellness to Our Communities, and is a Robert Wood Johnson Foundation Culture of Health leader. Stephanie D. Willding became the Chief Executive Officer in November 2019 of CommunityHealth, the nation's largest volunteer-based free health center. Steph is a skilled healthcare and nonprofit leader, adept at developing and implementing transformative initiatives across organizations. She is a seasoned thought leader with a documented record of increasing and diversifying revenue, using data to improve and adapt program performance, and advancing organizational goals through strategic and annual planning. Welcome, panelists. Thank you all for being here. I'm honored to be moderating this panel with you all. Before we get started, I do want to invite those of you watching to submit questions for the panelists using the Q&A function at the bottom of your screen. Feel free to write them in at any time, and we will ask and get to as many as we can during the program. Steph, I'd love to start with you. Thanks first for inviting us and Echo to participate in All in Chicago. We're really excited to be here. It's a really important discussion in charitable healthcare, and I was hoping you could get us started by briefly describing community health and then your personal philosophy of space and place and how it contributes to quality patient care.
Thank you so much, Josh, and Beth, Brianna, Jenebra, Cristy. It's so great to be on a panel with you, incredible leaders this morning. Truly an honor. This question has really been, and exploring this question has really been the theme for community health over the last about 12 months. You know, and before getting into where we are today, you know, I want to take everyone back to what we often call the before times. So before the pandemic and what it meant to be patient-centered. And before the pandemic, as safety net healthcare providers, you know, we would give a patient appointment and we would spend an inordinate amount of time really thinking through the barriers that that patient would have to overcome in order to physically show up for that appointment. And what that ended up really looking like was, you know, here's an appointment for this patient. Yes, it's affordable, but that does mean that now the patient has to be tasked with figuring out how to find transportation to their appointment. For a large majority of community health patients, transportation to our clinic is 3 buses, one way in the city of Chicago. For those not in the city, which is all of our panelists, that's a hike and can equate to up to an hour and a half travel time one way. So the burden is to find transportation on the patient, to take off half a day of work, to find childcare. And also now that patient is more food and housing insecure that week because they took off half a day of work to come to the doctor. And there is so much, when we really think about it, that is not patient-centered about that approach. And had it not been for the pandemic, I'm not sure we would have explored this question in the way that we have over the last year. And why is that? Well, in March of 2020, overnight, I think all of us on the panel can share that we pivoted to telemedicine. And we did so out of the safety for our patients and the safety of our staff during a time when we were all learning a lot about what exactly COVID was, how it was transmitted, and really learning how to keep ourselves safe. And the initial outcome that we saw from that at Community Health was that our no-show rate, which for non-healthcare folks, your no-show rate is the percentage of your patient appointments where the patient does not show up. And our definition includes they don't call, there's no advance cancellation, it's just a complete no-show. So before the pandemic, our no-show rate for our primary medical visits was around 19%. And almost instantaneously, that no-show rate decreased by nearly 10% overnight when we pivoted to telemedicine. And this data point really made us question what's going on here. And I can still remember the moment where it was like, aha, like literally an aha moment where the light bulb, you know, in a cartoon comes on, because of course it makes sense. We pivoted to telemedicine primarily phone consults. So rather than saying to the patient, good luck taking a day off of work, finding transportation, good luck with childcare, and good luck with being more food insecure, we just said, you know what, we're going to call you on your phone and we're going to meet you where you are. And that approach really ignited a thought process at Community Health about how else we need to continue rethinking space and place for point of care. So we are going to where the patient is and not requiring them to come to us. So we are taking on that burden of moving where the access point is, moving where that access door is for the patient, rather than saying, oh, here's the door, see you soon. And I think that this has been, when you talk about I won't say silver lining, because I don't know that there is one, but I am grateful that we have been able to use the pandemic and its learnings to really determine how we provide care moving forward. So how has this manifested so far at Community Health? Rethinking space and place so that we're meeting the patient where they are. One, we've doubled down on telemedicine. So we have made a significant investment in our own infrastructure, primarily the non-fun things to talk about. So IT infrastructure, we've done a complete network refresh at our headquarters location. We've also equipped all of our exam rooms to be hybrid exam rooms, which means every volunteer provider who is operating in our clinic can build a schedule that includes both in-person and video telemedicine care in each clinic session. So they can seamlessly pivot from an in-person visit right into a video visit, all in the same exam room where they're assigned for the day. So that's been huge. And we have really developed the policies, the workflows, the algorithms around that. And that's really served as the foundation for how we're rethinking space and place for point of care. But at Community Health, we pride ourselves on always wanting to take things to the next level. And the fact of the matter is telemedicine does have its limitations. For example, we need to know a patient's blood pressure. We need to know how our diabetic patient's A1C is performing. And so that is the limitation of telemedicine. But do you really want a patient traveling across town just so we can take their blood pressure? No. So what Community Health did is come up with a concept, and we've begun to pilot this concept of a telehealth microsite that is co-located in the neighborhood, or excuse me, that's located in the neighborhoods where our patients live and work, and is co-located inside an existing community-based organization that those patients already access as for food, childcare, English as a second language classes, legal support, etc. So in April of this year, Community Health launched our first telehealth microsite at Onward Neighborhood House. It's one of the oldest settlement houses in the city of Chicago, and I might add, an incredible partner. And what we did is open this telehealth microsite where a patient who lives and works in the community, and that community is Belmont-Cragen, again, 3 buses away from one way from Community Health's headquarters location. At this location, our patients receive an assisted virtual visit. So we have a medical assistant on site to take the patients, do their vitals, to draw labs if needed, and then the patient is roomed for their medical appointment, just like they would in a traditional setting. But rather than an exam room where you've got an exam table and all those typical things we all experience in our own healthcare access, it's a telemedicine room equipped with a high definition camera, broadcast lighting that adjusts to skin tones, as well as a high-low table that allows the table to move up and down so providers can get all of the camera angles they need during their telemedicine visit with the patient. So this does a few things. One, it takes the best parts of in-person care and the best parts of telemedicine care and brings them together. It removes the technology burden from the patient because we're placing that technology in their neighborhood. And it also helps us to be more proactive and direct with connecting patients with the various resources they need around their social determinants of health. In this case, for our immigrant patients, the location of Onward House, it's an immigrant welcoming center. So they are uniquely trained to help address and link patients with various needs that they may have. And this is really how we have been thinking through rethinking space and place and reimagining space and place for point of care, and how that has been implemented at the organizational level through telemedicine and the launch of a telehealth microsite.
Yeah, thank you, Steph, for framing that up. Listening to you talk about the evolution of care because of the pandemic reminds me one of my favorite of a quote that's really stuck with me during the pandemic, which is never waste the opportunity presented by a good crisis. And I think you've risen to the occasion, and I want to move over to Jenebra and Brianna. Church Health in Memphis and then Good Samaritan Health Center in Atlanta were both integral really to keeping those larger cities running and kind of were the backbone of the pandemic response in a lot of ways. Jenebra, I'd love to start with you talking about some of the unique characteristics Church Health has in its space that helped you rise to the moment. And then Breanna, when she's done, will you follow up talking about how Good Samaritan kind of transformed some of their facilities to meet the specific needs of some of the underserved patients you have in the area?
Well, thank you, Josh. I want to start off by just telling everyone thank you. I'm really excited to be on this panel. I have a lot of family in the west side of Chicago, so this is pretty exciting to hear what's going on and all the innovative things that are happening. For us, Church Health, which you can see behind me, is a massive building. We're about 1.2 million square feet. We're in a building that's 1.2 million square feet. And so when the pandemic hit, the first thing that we had to consider is how do we keep staff safe, right? There's a high school here, there's so many other things, there's retail space. And we really had a great opportunity. We have a ton of waiting room space, and we have a really cool waiting room that is located towards the west side of the building. And it was normally used for physical rehab. So we wanted a space where patients could drive up, get dropped off, and go directly to physical rehab without having to walk the course of this 1.2 million square feet building. And so that space has been used for our urgent care appointments as well as physical rehab. So when the pandemic happened, we shut everything down, as many other spaces have done. Many health centers were kind of challenged with what do we keep going, what do we stop? And physical rehab was an easy thing to stop, as well as some of our urgent care. And so we repurposed that drive-through space to become our drive-through testing site. And for, a multitude of months, with the help of volunteers and a few of our staff members, we were testing upwards of 300 people a day. And we became a community testing site. So no longer were we working directly with our patients, we were working with the entire city of Memphis. At one point, we were really the only testing location in the north part of Memphis. And so being in this location, we were able to serve a ton of people. We were able to work with local churches, local schools, and just try and really partner, even with the organizations that are within the building that were working from home. They were sending their employees to us to get tested because we were the closest site. And so it really gave us the opportunity to innovate, utilize our volunteer network, and utilize health professionals that were either retired or were no longer in the hospital system that wanted to help out during the pandemic. And so we partnered with other major facilities to get our testing back quicker than other sites, as well as using them to help us talk to patients and educate them when they did test positive for COVID. So it was one of the unique things about our location is that we could really transform this massive waiting room space and use it for something completely different. And, for a while we walked down there and it looked like a danger zone because there were, needles and like just different equipment everywhere kind of set up and not a waiting room space. But it was a really, really great opportunity for our teams to link arms across the city and use that.
Thank you, Jenebra. And Breanna, just a reminder, I was hoping to get you to talk about how Good Samaritan kind of transformed to meet the specific needs of underserved patients in Atlanta.
Absolutely. I can provide a few examples, and just a pleasure to be joining this group of people. And what I love is just that while each of these clinics has a very different community and different ideas and approaches, that there's a centralized idea of centering people and meeting people where they are. And that happens physically, and it happens in our attitudes and in our processes and how we show up to our patients. And I think that what is cool is how many different ways that can be accomplished and can be done. So I think perhaps one example I'd like to bring to the table to this discussion today is that we are an organization that's 21 years in existence, serving the uninsured and underinsured of the west side of Atlanta. West side also seems to be a theme on our panel today, I've noticed. But when 2015, we were looking at our patient census data and really started to think about, how many people experiencing homelessness are we reaching? And our numbers were fairly low given what we knew about the crisis in Atlanta. And so our question was, is that need being met, or is there something about the way we do care that is not approachable to people currently experiencing homelessness? So we started talking to people in that community, people who ran ministries, AA groups specifically for people in that community, and got feedback that shouldn't be surprising to anyone, that, you know, the healthcare system is often largely set up to benefit the healthcare system, that appointments are structured, they occur at certain times, different providers come different days. So if you need multiple services, there's multiple visits, and that it's really hard to organize your life around something like that when you are in a place of not knowing necessarily where you're going to get your next meal or where you're going to be sleeping from night to night or month to month. So we came up with a vision that said, you know, what if we take the space we're already in and we transform it into a clinic that meets the expressed needs of people experiencing homelessness? And so what that looked like for us is that we took Fridays and we said, you know, there are no scheduled appointment on Fridays. It is a walk-in, walk-up clinic that exclusively exists to meet the needs of people experiencing homelessness. Then we said, well, people need to be able to see everybody they need to see in one day. So we had integrated care with our behavioral health specialist. We added a certified peer specialist, 2 psychiatrists, our dental team, and ran a full dispensary saying, you know, if you can't afford medication, if your income is $0, then getting a prescription for $4 at Walmart might as well be $200. So really thinking through this process of how do we make this accessible. And what grew out of this was this really cool sense of community. We send a van to some of the shelters around the neighborhood, as well as a downtown park, where unfortunately many people do need to spend the night in Atlanta. So we help provide transportation to the clinic. For a lot of people living in this neighborhood, they walk over early in the morning. They know the gates will open early. They come because they also develop long-term relationships with us and with each other. We've had to modify it with COVID, but for one morning, one of my patients said, you know, there are people like me that have to see you, then I got to see the psychiatrist, then I have to see the counselor, and I'm hungry. So we started adding breakfast, which has now become sack lunches for COVID safety precautions. But this idea of saying people, when asked, will tell you what they need. And what if we start by just believing them and changing what we do to better meet that need? And I'll end by saying, you know, as we started developing and kind of watching this program grow and evolve, we actually took some time to do kind of a qualitative analysis of what was happening. And we had a master's in public health student conduct these interviews so that staff weren't present, and just asked, you know, why come back? You know, and when your life is moving and you're in different places, why come back to here? Why tell friends to come here? What is it that you value most? And I was expecting, I get free medication, I can see 2 doctors in the same office visit. But what we actually found, while those things appeared, the largest theme centered around, they remember my name when I come to the door. I see the same faces over and over again. I've never been treated like a number. I've always been treated like a person. And that we've even had about 5 different patients interviewed expressly say, this is the closest to family that I've had in Atlanta. And I think what it did for me is it reminded me that, you know, sometimes there's funding limitations, sometimes there's reasons we can't move or redesign in the way that we want, but we can be really, really creative in the spaces and places available to us. And sometimes there are solutions in just changing how we show up. And that when we move how we approach care, we also change the type of care we provide. When we say we meet you and we care about your story and we want to know, you know, what happened versus what's wrong, it changes how we approach those visits. And it's been this very powerful reminder to me in my career and to us as an organization about what it means to flip healthcare over and try something new. And I think that's one of the strengths that's shared by everyone on this panel in the free and charitable care world in general, is this desire and ability and creativity to say, just because it hasn't been done this way, why not try it and see if we can't better meet the needs of those we serve.
Yeah, thank you for that, Brianna. I think there's some algebra there between the kind of willingness to change how healthcare is done in the free and charitable space and the Venn diagram of the patients that free and charitable care tend to serve and who we defined as essential workers at the beginning of the pandemic. I don't think a lot of people recognize how important free and charitable care was to mitigating the pandemic as much as we did in the beginning. Quickly, before I move on, can you give me about half a minute? I know you took a specific part of the Good Samaritan facility at the beginning of the pandemic. Good Samaritan wasn't as well equipped to do the drive-through as Church Health was, but you kind of recognized a specific need and changed the space there. And I'd love to hear you talk about that for a little bit.
Sure. So we actually have a full-time farm on the campus of Good Samaritan, and food access is a big part of what we provide in the community. And in March of 2020, we were supposed to have a grand opening of our health pavilion, where it was going to be the permanent location of our farmers market, as well as a separate community fitness building that was run in partnership with the YMCA. So if you guys think back to March of 2020, the world shut down. And so we had this beautiful space and had the opportunity to partner with CVS to bring in what was one of Atlanta's first rapid testing COVID-19 sites. And they are still an active site. We've tested about 250 people a day at the peak. And what our site enabled, though, is that what we started hearing was that everywhere you can test requires a car. It's drive up, it's stay in your vehicle for safety reasons. But for many of our patients, they didn't have a vehicle. So we became a walk-up test site clinic, all run outdoors. So the machines were able to be kept inside, but the health pavilion served as a safe outdoor spacing where people could drive and park in our parking lot. They could walk, they could take public transit, they could use whatever means they needed to get to us and be able to walk up to that site. And for us, it was this very cool example of something that was a big disappointment, something we were excited to open, wasn't going to be able to do and still hasn't. But, we're now on well over a year of being really an essential testing site that has decreased some of the barriers to testing that our community was facing.
Yeah, thank you for that. I think that's a really important example. Before we move into talking to Cristy and Beth, starting with you two, rethinking space and place in healthcare, I want to kind of give you some tangential homework and kind of set the stage for how big of an issue this is kind of across the entire space. So I just sent a link to a YouTube video of a Tedx talk by a gentleman named Doug Dietz, who is an industrial designer at GE Healthcare, at least at the time. He gave this TED talk. And he talks about this new MRI machine that he had designed that he was all excited about. And he went to see its first day in a children's hospital and kind of recognized how they need to rethink how they design machines based on the reaction of the experience of this little girl who's walking back to the MRI room. And I'll leave it at that. It's a really powerful talk and it really illustrates the point about how healthcare needs to be rethought at every level and kind of across the whole spectrum. So Cristy and Beth, you were both involved in opening and operating a brand new charitable clinic during a pandemic. That's no small feat. Opening a new clinic is hard enough on its own. And then when you do it during a global pandemic, you really up the degree of difficulty. Cristy, can you just describe what it was like to open St. Clair Community Clinic in a small rural community like Pell City for people who truly had no access? And how your team remodeled and restructured because of COVID?
And thank you so much, Josh, for inviting me to be here and a panel, and just thank you. I'm so excited to be here and be a part of this conversation. We are newer to the game, and I think we are basically 3 years old. Our clinic came as a result of just a need in the community. My real full-time job is I am a nursing faculty at a community college, and we are located in a rural county, St. Clair County in Alabama. And so I think what maybe we bring to the table, and it's so exciting to hear what everyone is doing, and hopefully we will be larger and bigger one day, but we just stepped out. And I think what we can maybe bring to the conversation is that really there are so many communities across our entire nation that really have no health care. We are basically 30 minutes outside of Birmingham, but in our county we had zero opportunity for residents who were uninsured. And so we began to see more and more people coming to us as nurses, as nursing faculty, as a community college saying, you know, what can we do? We have this patient whose blood pressure is 190/100. What can we do? And my response was, I don't know. We can take a blood pressure, but I don't know what to do at that point. And we found that residents in our county were having to go over county lines to other larger metropolitan areas to be able to access care. So we initially partnered with the city of Pell City, where we're located, and also with our local hospital, which is St. Vincent St. Clair. We found, as many of you have described so beautifully, that partnerships is absolutely where it's at. We have a lot of people who are doing good things, but in our county, we really did not have that dot connector. So while someone may be able to drive or find transportation or get a ride over to the other side of the county to get food, but yet they still didn't have their medications. And what we have found largely, as I know everyone else has, is that in the absence of the ability to get that health care, people wind up in the emergency room. That is where they go, and that puts an undue difficulty on our emergency rooms. So in the midst of the pandemic, we found that that was true even more so. And so we had been operating several months to a year before the pandemic hit. And we had begun to develop those relationships, you know, that Brianna described, those relationships where people knew that when I call St. Clair Community Health Clinic, I'm going to talk to Cristy or I'm going to talk to Kim, and that they actually valued and had trust in those relationships. And so we found that as the pandemic approached, that we saw this new level of panic, of fear, of what is going to happen to me now, where previously, yes, I might have my blood pressure medicine, but now it was an emergency to have that blood pressure medicine. And so on a smaller scale, we really looked at some of the same things as the other panel has described, which is how does our space operate? How difficult is it for people to get here? Do we need to change the layout? And yes, we did go to a telehealth model because our clinic is ran 100% from volunteerism. So our concern is also about a lot of our providers. A lot of our providers are elderly, and we're concerned about their health and keeping them healthy and keeping them able to volunteer. So we did have to look at the telehealth, and again, the telehealth model has been a fantastic transition in that we do want to see people face to face. We did, as I'm sure other people did, we put blood pressure cuffs in the hands of our patients so that they would be able to use those automated machines to report to us. We put blood sugar machines, we put thermometers, whatever we could put in their hands to utilize from home. We have done some of the smaller microsites throughout the county, but here as we are today, we have continued to utilize the telehealth model and will continue to. I think for us, being in a smaller rural community, where we have a lot of people that are in even more rural areas, we're in Pell City, which is one of the larger areas in the county, but we have people who are located probably 30 and 40 miles from our site. That some of the things that we have focused on the most are making sure that they do have that access via telehealth. We have a lot of patients who truly don't have a functional phone or have very few minutes or have very limited access to internet. And so those are challenges that we have had to look at and continue to look at how to overcome. Mental health, I would say the need for mental health has increased as much as 50%. The need for mental health evaluation, the need for counseling, the need for mental health medications. And as I think it was Brianna said, if you can't, before, if you were struggling to get your $4 medication at Walmart and now you've lost your employment or you don't have $4, how are we now going to put that medication in your hand? And so all of these are things that we had to quickly look at and quickly make adjustments. We're continuing to look at how to we also have seen more of a homeless population. Our homeless population in our county has sort of been here but hidden, if you will. But now people are beginning to come out of the woodworks. Maybe they were marginally housed and now they're not housed at all. And so we also have had to look at ways to address this population. So those are some of the things that we have done in terms of addressing that within our community, being a smaller or rural-based, totally volunteer community health clinic. And I will say that it's a privilege to be in this role. It's exciting to be in this role. And it is awesome to see that as we have become the dot connector in our county, that a lot of services that are happening sort of in isolation, that now we're beginning to come together and say, what can we do as a county to address this problem, so that in our own way, we don't have people who simply don't have blood pressure medicine because they don't have a ride to the clinic. Okay.
Yeah, thank you for sharing that. You illustrate this idea of the things we're going to keep in a post-pandemic world. And I think rural healthcare really has a strong opportunity to deliver better care. The other thing you brought up was being a dot connector. So I'm going to talk to Beth Kolb about that a little bit. Beth, Trinity Health Center opened in DeSoto County, Mississippi in October 2021, an incredibly challenging time. So I'd love to hear you give us just a few seconds on what it's been like to attract new patients during a pandemic, but even more about what's really special about Trinity Health Center's space and place in serving your community.
Yeah, thank you, Josh. Again, thank you so much for inviting me to be a part of this. As everybody said, this is an honor to be with people from all over the country talking about something that we all have in common. We opened in the middle of the pandemic, October 2020. Not the ideal time to be starting a clinic, as we found that even those with insurance weren't running to the doctor's office. There was a lot of fear. There's still a lot of fear of, if I go to the doctor's office, am I going to get COVID? And so it was tough to attract new patients when you add a pandemic with trust. When you open something new, people don't automatically trust that. And so it takes some time to, and I think Brianna was saying it before, where now when our patients come, they come not just because we're the place where they can get care as an uninsured patient, but they know all of our staff's name. Our staff knows their name. We're calling them when they miss an appointment, and they feel loved as a human, not just seen as a patient. And so that's been phenomenal. But what makes us different that Josh is speaking to is we're located inside of a dream center. And so if you're not familiar with the Dream Center, the concept was started by the Barnetts in California, but we're a community of compassionate ministries within one location. And so we have an education ministry within there. We have food ministry and clothing ministry, and now a clinic as well, all under one roof. And so the collaboration of a holistic approach to helping someone who's in need, we're able to communicate with each other and say, hey, I have a patient who we found out has food insecurity, or I have a patient who has a child who has an educational need. And then the same happens the other direction. We have, one of the things we said from the beginning is we would never want to find out that we have kids within our what's called DeSoto Grace program that are there for an educational and a mentoring need, and find out that them or their parents are uninsured and not being cared for. So those dots, as Cristy said, get connected very quickly when you're all of the same mind and the same vision, and you have the benefit of being located in the same space. And so it allows that connection to be easier, and it takes away the need for, I've got to do everything. We know how to do healthcare in the clinic at Trinity Health Center. That's what we know how to do. We have medical providers and people with a passion for providing healthcare. And it's hard when someone comes in and they have a need for food. All of a sudden, you want to be in the food ministry. But that's not what we know. That's not our wheelhouse, but it is the Dream Center's wheelhouse. And so we can take and say, hey, we found out they have a food need, or we found out they have an education need. And so those partnerships continue to grow, where we don't have to say, okay, we have to add a food component, or we have to add transportation, because we've partnered with someone who does transportation in our community. They bring people to our clinic. We can call them when somebody doesn't have a ride after their appointment. And it allows that collaboration to work better, and it also builds that trust level. They may already have a trust level with the Dream Center, or they may have a trust level with us, which then when we speak to the Dream Center and say, hey, you can trust the Dream Center, they already have that with us. And so they kind of build on each other. So it's been a phenomenal partnership to get us, especially during that time, to get us started when there was such a trust level pandemic, everything happening at once. It's been a great benefit for us.
Yeah, you touch on a couple of really interesting things. I think, first the comparison between how Trinity Health Center has handled, meeting the needs of people versus what Steph talked about in needing a microsite in another part of town to mitigate 3 bus rides. It's just powerful how you can solve kind of the same problem from 2 different perspectives. Quick reminder, Angel put it in the chat, but if you have any questions for the panelists, please feel free to put them in the chat. I do have more, and we are running out of time. So if you can keep answers to just a minute or 2, please do. Jenebra, I'm going to start with you. Church Health started in Memphis in the late 80s in a small house in Midtown, and over the years kind of grew to 13 or 14 buildings. I don't remember, but it was a sprawling campus and there were buildings everywhere. And is now in a gigantic consolidated space. Just to clear up, Church Health is not more than 1 million square feet. Church Health is 150,000 square feet in a 1 million square foot building. But can you talk about some of the key differences in delivering patient care now that you have everything under one roof?
Yes, and I have to apologize. My internet connectivity is going in and out. So if you have trouble hearing me, my apologies on the front end. But you're absolutely right. And I'm really grateful to have worked here during that transition of running around. I got the best exercise in my life going between the different 13 buildings. And to Josh's point, we started off in 87, we had 1 building and we continued to move to Crosstown. And when we were able to move here, it completely shifted our care delivery. Not only were we more integrated in a neighborhood that we currently serve, we were closer to the people that we served. It was along a bus route. And so it made it a lot easier for us to see the patients that have been our patients for 20 plus years. We also were able to double all of our exam space across all service lines. So optometry and behavioral health. And so it completely shifted our model and how we wanted to deliver care when you go from 3 exam rooms to maybe 8. And so, for example, in our medical clinic, one of the coolest things about it is we are able to integrate multiple service lines within our medical clinic. We are able to fastly get patients into physical rehab. So if any of you all understand that once someone needs physical rehab, there's no point in waiting. And since we're co-located, we're able to quickly send someone down the hall. We have behavioral health consultants that are integrated within our clinic spaces that do a PHQ-9 and a GAD-7. For every patient that comes on site, they can deal with any kind of behavioral health intervention in the moment. We have health coaches that work with our patients on diabetes and hypertension in the moment and can do insulin teaching and titration right there where the patient doesn't have to leave, they don't have to go anywhere else. And most recently, and this started actually during the pandemic, is we were able to put retina cameras within our medical space. For those that are interested and understand optometry, the eyes are the windows to the soul and windows to the body. And so we're able to easily identify chronic diseases before they actually manifest in a more primary care setting. So we're able to quickly identify patients with diabetes and hypertension and work with them right then and there instead of waiting for our eye appointment. And another cool thing is our kitchen that's located within our space. So we have a network of volunteers, staff members that cook meals. And as our patients are leaving their appointment, they can actually get a few meals for the week, which has been probably one of the best uses of space, is having things so proximal. And so our patients are either able to get food or sometimes go into the kitchen and learn about how to use the foods that they have in their own houses to better take care of their chronic conditions and their health. And so it has been an immense blessing to move over here and not have to trek across town. Just to give a quick example, our dental clinic was located almost 5 blocks away from our medical clinic. And so it wasn't a matter of, can a patient walk there? They would sometimes have to get on a bus or sometimes have to get in a car, which is never good for care delivery. And so this new building has given us the opportunity to truly integrate and really expand the services that we're offering to our patients.
That's excellent. Thank you. I think that idea of navigation, it's so difficult to navigate the healthcare system, even when we've got the good insurance, and the thought that you can bring everything into one spot and make it a less oppressive and intimidating process for people is just fantastic. We are running short on time. I want to get to a couple more things. So tight answers, if you don't mind. Brianna, I'm going to go to you next. You co-authored an incredibly smart and insightful book, How Neighborhoods Make Us Sick. I'm going to drop the Amazon link to that in the chat. That really talks a lot about the outside influences that kind of drive people's health. And can you talk to us about how you use Good Samaritan space and place to kind of mitigate all these things that happen outside of the clinic and outside of your purview, to deliver excellent care to your patient base?
Absolutely. So the idea of social determinants of health is just simply that, we know that only about 10 to 15% of premature death in the US can be fixed within the classical medical system. So that really tells us that, most of what's driving premature death, as well as racial disparities, are things like education and housing and food access and employment, and how systems of oppression, socioeconomic status, racism play into the disparities in each of these areas. And so at Good Samaritan, we really focus on centering health and understanding that medical care is a piece of that, but by no means the most important. And I think that's really transformed from our initial vision to, as we grow and seek new programs, how we do that. So some of those examples, as I mentioned, having a farm. I didn't expect to be working with farmers when I went to school long ago. And now I can't imagine any other way, how much I've learned from them about food and how it's sourced, and what makes it affordable and what makes it safe, and passing that knowledge on to patients. We have a kitchen where we prepare food and use it for a teaching space. We have a certified peer specialist and care management to help facilitate that. But I will echo what the other panelists say is that we really say, what does our space allow us to do? And for that, there's fitness, there's a kitchen, there's a farm, there's a market, there's dental, there's medical, but there's not housing. I can't put anyone in a safe place for the night here at Good Samaritan. And so I think that's really where partnerships help fill in that gap, is to ask that every need is valid and matters. And do we have a way to address that well in the space and the place that we have? And when we don't, how do we think creatively about where are those spaces already existing and who does that work well? And how can we build good, effective two-way partnerships, as Beth articulated so well, that help connect patients to the needs that we can't always meet right here within our own campus.
Yeah, thank you. And Steph, I'd love to turn that question to you as having recently opened a microsite with a partner. How did you know you found the right partner? How did you find the right partner? How has it worked? How do y'all collaborate? Just kind of walk us through that whole thing, because that is daunting, I think.
Yeah, I have to say, when you think about that on paper, it does feel daunting, but that ended up being one of the more seamless parts of implementing this telehealth microsite. In part because Onward House as an organization is just a really incredible partner. So generally speaking, as Brianna mentioned, and I know someone else mentioned as well, I think in healthcare, when you center health first, that's incredible. But if you're trying to have a diabetic patient maintain their wellness and they don't have access to food, they're never going to achieve their treatment plan goals. And so that's why partnership is so key, because as someone else mentioned, like, we can't do it all as healthcare providers, but I do think we have a responsibility to serve as the central hub to screen and connect where we can. And this is where having a partner that had food access was one of our top priorities. And Onward House does have an emergency food access program, but also making sure we had a partner that could understand the unique needs of our patients who are predominantly immigrants. And finding an organization, and this one's sort of harder to find. It's almost when you're interviewing someone, you never know how it's going to be until they're in there. Finding a partner that approached problems like community health and were willing to take a risk, right? Because this telehealth microsite was a concept, and implementing it was as a pilot was really a risk, because we didn't know if it was going to be successful. And so the hiccups as far as partnership development have been very minimal, and I liken them to having a roommate. right? You're sharing of space, you're sharing utilities. You want to make sure you can access the space when you want to. They want to close at 5, those kinds of things. All logistical that can really be worked out. So for our future microsites and expansion, what we're really doing in partnership is finding partners that really kind of tick those 3 boxes I mentioned. So food access, innovative thinkers willing to kind of be bold and act bold and think boldly, and then really a partner that understands the unique needs of our immigrant community.
Yeah, thank you. I know we're really running out of time. Last minute reminder, if you have any questions that you'd like to ask the panelists, now's the time. While I'm waiting for that to come in, Cristy and or Beth, I'd love to hear you share a story, if you can, about a patient interaction that you've had in your new clinic that illuminated the challenge that you have with this space in place, and kind of has made you start thinking about opportunities for expansion and that sort of thing.
Beth, would you like to?
Yeah, I'd be glad to. Wow, that's an interesting question. I think for us, we've had a couple of different things that have happened because our clinic is, we are only providing primary medical care within our clinic. So we found right away that a lot of our patients, as someone mentioned earlier, have a lot of mental health needs. And so one of the things that we did recently was we've partnered with a counselor in our county who has her own practice. And she comes twice a month to our facility. We set up one of our exam rooms as a counseling space. And so as long as they're an existing patient of Trinity Health Center, they can receive counseling, which if they can't afford medical care, they can't afford counseling, mental health care. It's just too expensive. And so she's donating her time and our patients can come and receive care that way. One of the other things that we found a lot with our uninsured patients is dental care. And we didn't build our building with dental facilities inside of it. That's quite a challenge. And so we've made partnerships with local dentists that said, I want to be a part of what you're doing. And rather than us going through the process of adding to our space a full dental facility, they're partnering with us and allowing us to send patients to them. And they may take their day off or one afternoon where the dentist and a dental assistant are willing to come in and see a patient for us. And they're all setting it up different. Some of them are saying, I'll do this many pro bono cases, or we'll do a discounted rate based on the same sliding scale you use. And so that's been some of the things. That's not a specific patient, Josh. I apologize that that's not exactly what you asked, but those are some of the areas that have made us rethink how do we use our space the best we can and partner with others and maybe even use their space to provide some of this care.
Yeah, thank you, Beth. That's perfect. I could listen to you all talk about this for another hour. I don't think Angel's going to let us, unfortunately. Thank you all for being here. I loved kind of the through lines and some of the themes of expanding your footprint through partnerships and then kind of retracting back into your own spaces. I think there's just a lot of insightful, powerful things there. Thank you so much for sharing your time. Angel, I will give it back to you. Thank you for having us.
Thank you so much, Josh, and to our panelists for today's great conversation. I'm also very sad that it went so fast and we had to cut everyone off a little short. As I mentioned earlier, today's program was brought to you by Community Health. All of your ticket sales and any donations you make today will support Community Health's mission to serve those without essential health care. Please consider making a contribution now to support Community Health. Instructions should be appearing on your screen, and I'm going to ask Laura to drop a link into the chat for you as well. On behalf of the staff, board of directors, and volunteers at Community Health, I want to thank you all for being part of our All in Chicago event series. I hope that you are all leaving today with ideas for how we can work together to make the vision of access to care for all Chicagoans a reality. We have 5 more events coming up throughout the rest of this month, and they are all free to attend. I encourage you to check out our website, allin-chicago.org, to learn more about the great events coming up and register to be all in. We all have a critical role to play in this effort. Thank you for being a part of today's event.